Hello guys, I'm Dr. Ranjan, your pharmacology faculty at Marrow, and guys, today we'll be discussing all the recent MCQs which have been asked in the recently conducted INI-CET examination. And whatever MCQs are there, guys, I'll try to give you the best possible answer to these questions. Some are controversial. So let us not waste time and straight away begin with the questions, guys. Number one question, you can see, which of the following MAB, monoclonal antibody, is a HER1 inhibitor? See, HER1 is also known as EGFR, or epithelial growth factor receptor. Now see here, many of you guys thought that this MCQ is wrong because overall, if you look at these drugs, cetuximab, panitumumab, and necitumumab, all of these, they act on EGFR. They act on HER1, right? They act upon HER1. Now, pay attention. The MCQ is asking not about acting upon HER1, inhibitor of HER1. Now see here, pertuzumab would not be the answer here for a simple reason. Pertuzumab, it is an inhibitor of HER2, right? It is an inhibitor of HER2. So if B, C, D are three options, what would be the answer? Let me explain to you guys. It's a difficult MCQ. Right. So suppose this is your tyrosine kinase enzyme that is present inside the cell. It is connected to HER1 or EGFR receptor outside the cell, right? Now, if I have drugs like, let us say, panitumumab, so panitumumab, if you look at panitumumab, it is a MAB. It is immunoglobulin G2 subtype of a MAB. And when I give a molecule of panitumumab, what it does, it binds to HER1 receptor and blocks it. And because of which epithelial growth factor, it cannot bind. This is the primary mechanism of anti-cancer effect by panitumumab. But let's have a look at the drugs like other drugs like cetuximab and necitumumab. Now see, these are also MABs, but they're immunoglobulin G1. And there is slight difference in the mechanism of action. Now see, what happens is, this is important. Now suppose these MABs, suppose they look like this. So they also bind to HER1 receptor EGFR, but they also bind to the NK cells, natural killer cells. Now, it is something like BITE. There is a type of MAB called as BITE, bispecific T cell engager. Something like that, not exactly. So what it does, the cetuximab and necitumumab, they bind to HER1 receptor. They also bind to natural killer cell. And because of that, they induce death of the cell, cancer cell, owing to natural killer cells, right? It is not because EGF is not able to bind to EGFR. And that is the reason why, what is the answer here? All of you have guessed by now. So the answer here is, guys, the best answer, possible answer is panitumumab, because it blocks HER1. Cetuximab, necitumumab, they do not block HER1. Rather, they induce lysis of the cells by binding to HER1 as well as binding to natural killer cells. So it means what they bind it to HER1, but they do not block it. So you can imagine how heartless the professor of AIIMS can be, isn't it? Now forget about MBBS students. Even MD Pharma graduates cannot answer this. Is so difficult. And forget about MD Pharma graduates. All the recall videos I have seen, they have changed the MCQ conveniently into which is not an inhibitor of H1 and given answer as pertuzumab. Right. So the MCQs are not wrong in AIIMS, guys. It's a right MCQ, but unfortunate such MCQs are asked. Nevertheless, for us as a student, what we have to do is mark the right answer whenever if it is repeated. If in the exam you could not solve it right, it's okay. Go easy on yourself. Nobody would have done this right? All right. Now coming to the next question, is quite easy one, guys. Intermittent administration of teriparatide predisposes an individual to which of the following complications? Now look at the options. It is not a difficult MCQ, guys. A, osteonecrosis of jaw. B, subtrochanteric fractures. C, net loss of bone mass. D, osteosarcoma. Now here, the answer is D, osteosarcoma, and I have taught you this in the Marrow lectures. Because of osteosarcoma, teriparatide, it is contraindicated in Paget's disease, isn't it? And the use of teriparatide in treatment of osteoporosis, it is maximum 2 years. When we know that bisphosphonates can be used for 3 to 5 years, when you know that denosumab can be used for 3 to 5 years, this drug can be used only for 2 years. That is the reason. If you look at these two, osteonecrosis of jaw and subtrochanteric fracture or coccyx fracture, these are seen with bisphosphonates, isn't it? Easy one. Net loss of bone mass is wrong, guys. They will not. Why would I use a drug in osteoporosis that would cause net loss of bone mass? It's a stupid, option, so to say. Rather, teriparatide increases bone mass or increases bone formation, right? Now, guys, moving on to the next question. Which of the following drug acts as an inhibitor of PCSK9? This is a repeat. It has been asked twice in INI-CET and NEET PG, and you know what is the answer? Evolocumab, guys. Now, I'll prepare you for the upcoming INI-CET exams. They've asked you inhibitor of PCSK9, evolocumab. Now, what are the 2 points they can ask you about evolocumab in the future? See, another drug here is alirocumab. Remember, 2 drugs are there. In case they forget about evolocumab, they might give you alirocumab in the options. Now, both these drugs, they cause a maximum decrease in LDL. Earlier, this was caused by statins. Today, it is due to PCSK9 inhibitors. Plus, they also decrease lipoprotein A. Now, lipoprotein A was earlier decreased only by niacin. That is the MCQ they used to ask. So, these are 2 possible MCQ points they can ask you here, right? These are 2 MCQ points they can ask you. Second point, they can ask you, one, they had asked you about inhibitor of PCSK9. If I change this MCQ, which of the following drug, second MCQ, which of the following drug inhibits synthesis of PCSK9? Now, these 2 MCQs might seem similar, but they're not similar. They're different. What is the answer here? I've told you guys. What is the answer? It is inclisiran, isn't it? So what is inclisiran? It is a small interfering RNA. It is a small interfering RNA that antagonizes, AN means antagonizes, small interfering RNA that antagonizes synthesis of what? PCSK9. So remember, inclisiran inhibits synthesis of PCSK9. Evolocumab, alirocumab, they inhibit PCSK9 itself. What are the 2 more points they can ask you? Number 1, maximum decrease in LDL, evolocumab. Decrease in lipoprotein A. One is PCSK9 inhibitors, another one is niacin. But I suppose they won't ask niacin because it is not that used commonly nowadays, isn't it? All right, guys, moving on to the next question. Again, it's an easy peasy. G2P1 delivered preterm baby 36 weeks. The baby was admitted to NICU for a week and was given express breast milk. Unfortunately, the baby did not survive, right? Which of the following drugs can be used to reduce engorgement and pain of the lactating breast? So obviously the baby is dead. Unfortunately, lactation is not required. That means I do not need prolactin. I do not need prolactin, guys, right? To be synthesized from the pituitary. All right, which hormone is called as prolactin inhibiting hormone? The answer lies in physiology. Prolactin inhibiting hormone is dopamine, guys. So dopamine, by binding to D2 receptors, which are GI subtype in the pituitary, it decreases release of prolactin. So if I want to give a drug to decrease release of prolactin, I have to stimulate these GI subtype of D2 receptors. And for that, 2 drugs are used. One is cabergoline, which is in the option. Second, I can use is bromocriptine. But bromocriptine causes more nausea, vomiting, so to say. And that is the reason why the preferable drug is cabergoline, right? Other drugs are not important here. Pramipexole, though, it's a D2 agonist, but it is not used for this indication. It is used only for treatment of what, guys? Parkinson's disease, right? That's why I've discussed about that. Now, moving forward, guys, the next question, which of the following anti-diabetic drugs can cause unexplained diarrhea? All right, here, let me tell you first about the answer. Here is metformin. Now, why metformin causes diarrhea? There is a very interesting explanation to this. So bear with me for small time. I'll explain you guys. Suppose this is my intestine, right? Suppose this is my intestine. And in our intestine, we have a pump here called as OCT1. So it is organic cationic transporter 1. Now, this organic cationic transporter is something that is responsible for absorption of metformin. So, metformin is absorbed from the intestine by OCT1 or organic cationic transporter 1. I hope this much is clear, right? Now, unexplained diarrhea. Diarrhea that is seen, remember, this diarrhea is seen only in some patients. So why in some patients, right? Because in these some patients, genetically, there is a decreased expression of OCT1. If there is a decreased expression of OCT1, that means what? Lesser OCT1 means this metformin would not be absorbed completely. So there is more metformin present in the lumen, and this is responsible for GIT upset like nausea, vomiting, diarrhea, etc. can be seen. So I've told you the logic behind it. So not just mugging of the PIQ. Tomorrow they might ask you which pump is responsible, like an P-glycoprotein pump or MDR pump or ABC pump or OCT pump. Your answer would be OCT1, right? All right, this pump OCT1 can be blocked by proton pump inhibitors and verapamil. All right, so what is the drug interaction I'm hinting at? If my patient is on PPI or verapamil, that patient would be a higher risk of diarrhea, right? The patient would be at a higher risk of diarrhea because of inhibition of this pump. Even in a normal person, the diarrhea risk would be much higher. So these are the MCQ points they can ask you guys. Which pump is responsible for causing diarrhea? OCT1. Which drugs can increase the risk of metformin-induced diarrhea? Which drugs? PPI and verapamil, right? Which of the following anti-leprosy medication causes skin pigmentation? Guys, here the answer is clofazimine. Now remember, the clofazimine drug itself is in red color. It is red color. Now, what happens with this drug? This red color drug, its crystals get deposited in the skin lesions of leprosy. So leprotic lesions are there, right? On those lesions, these crystals, they get deposited and they give an appearance of red-brown appearance of skin. Red-brown appearance of skin. But remember, this is reversible. This is reversible, but it might take years to be reversible. It is reversible. So what are the points they can ask you here? What is the color? Say they have asked you pigmentation can be seen, right? In future exams, what is the color of pigmentation? Red-brown. What causes pigmentation? The drug itself, which is red in color. Number 3, is it reversible or irreversible? Reversible. Is it immediately reversible after stopping the drug? No. It will take years to be reversed, right? All right, yes. Now moving on to the next question. Which of the following diuretics is matched correctly with its location of action? Let us see. See, osmotic diuretics, DCT. No. Osmotics, diuretics, they act upon PCT and loop of Henle mostly, right? Thiazide diuretics, PCT, wrong. Thiazides, they act upon DCT. Carbonic anhydrase inhibitors, PCT, yes, this is correct, right? Potassium sparing diuretics, collecting drug, this is correct. So it's an easy one, guys. CD, where is CD? Where is CD? Where is CD? Option B, C and D. So it is an easy one. It's not a difficult one. And I don't think it needs any kind of explanation, isn't it? Now, which of the following acts by suicide inhibition? Now, suicide inhibition, it is a multiple choice type question, guys. Here, suicide inhibition are shown by two drugs, ritonavir and benzbromaron, right? Now, what is suicide inhibition? Suicide inhibition is when a drug will bind to an enzyme by forming covalent bonds. And you know that you cannot break down these covalent bonds. So this binding is essentially, it becomes irreversible. Irreversible, right? Now here, ritonavir, it binds to an enzyme called as protease. That is the reason why it is the answer. Number 1, and it blocks irreversibly. You might be thinking, sir, why benzbromaron? After all, it is a uricosuric agent, isn't it? But remember, benzbromaron, it is not only an uricosuric agent, it also blocks xanthine oxidase. It also blocks xanthine oxidase. And these two drugs, so xanthine oxidase inhibition is not a primary mechanism of benzbromaron. It is a secondary mechanism, right? Nevertheless, it does. Ethylene estradiol, spironolactone, guys, it is not a suicide inhibitor, right? It competitively binds. Spironolactone competes with aldosterone for binding to your mineralocorticoid receptors or aldosterone receptors. So it is competitive inhibition. It is reversible, not irreversible, right? So answer is, guys, what is the answer? CD, CD, CD. What is CD? CD is option D, right? Number 11. A patient known case of diabetes shows microalbuminuria on urine analysis done twice at an interval of 6 months. Renal function tests are normal. Which of the following drugs is not useful in preventing the progression of renal damage? Right, now look at this. Finrenone, hydrochlorothiazide, ARBs, SGLT2 blockers. Now guys, out of these, if you look at, I have taught you about Finrenone. Yes, the use of Finrenone, it has been approved. It is an aldosterone blocker, antagonist. Eplerenone, Finrenone. The only use of Finrenone, it is used in diabetes mellitus to delay the progression of CKD. I've taught you that in marrow, right? Angiotensin receptor blockers, not only that, for the matter, any RAS inhibitors, they're preferred. Why? I've told you this. The reason why we prefer is because RAS inhibitors are the drug of choice for treatment of diabetes mellitus with hypertension. And one of the primary reasons is they delay nephropathy or CKD, right? SGLT2 inhibitors, yes, they do. And in fact, SGLT2 inhibitors, what can they delay? They can decrease, number one, they can decrease mortality in CHF. This is one of the MCQs they would ask you, and I've taught you this in marrow as well. Mortality in congestive heart failure. They can decrease serious mortality, cardiovascular mortality like MI, stroke, angina, etc. can be decreased by these drugs. Plus, they can decrease CKD progression as well. So SGLT2 blockers, these are three things you need to keep in mind. Now, two things have been asked. This has been asked. What have been asked? Now I need to prepare. See, if I'm preparing for a competitive exam, I have to be pretty sure that what I need to target. This has been asked. This has been asked. Now, what is left to be asked? A decrease in serious mortality. Now, remember, a decrease in cardiovascular mortality can be seen with three drugs. One is our very own metformin. Second is SGLT2 blocker. Can you tell me, guys, which is the third one? Let me know in the comment box. The third one is GLP-1 agonist. So these are the only three classes of drugs which have been seen to decrease cardiovascular mortality, guys. All right, moving on to the next question, guys. Coagulation profile monitoring is required for which of the following drugs? See, coagulation is not required. Rather, it is important to remember, not required. Monitoring is not required. So monitoring, where do you not require monitoring? I've given you the mnemonic, guys. If you remember, the mnemonic was DLF. DLF, D for DOAC. DOAC, where we have dabigatran, apixaban, edoxaban, etc. L for LMWH, like enoxaparin, tinzaparin. F for fondaparinux. Fondaparinux. And the logic I had given you, why this mnemonic, isn't it? Why this mnemonic? The reason being, see, DLF is a builder. If you guys know, DLF is a builder. And when DLF builds houses, they're very costly. And whenever they build houses, they give you a timeline and they always deliver on timeline. So their houses are costly. So you don't have to monitor whenever construction is being done by DLF. Any other XYZ builder, you have to go and constantly monitor the construction, if it's happening or not, right? So anyways, this is a mnemonic for which we do not do. So just rule out enoxaparin, right? Coagulation not required. Yes, not required. Fondaparinux not required. Dabigatran not required. So what is our answer? Answer is A, lepiridine. So with lepiridine, we monitor APTT. With UFH, we monitor APTT. With warfarin, we monitor PTINR. So three things are monitored. Where do you monitor APTT? The lepiridine-like drugs, which are your parenteral direct thrombin inhibitors. UFH, which is also an anticoagulant where I monitor APTT. PTINR with warfarin. So what is monitored? What is to be monitored? And which drugs I don't monitor? It's a simple, plain and simple MCQ, guys. Now moving on to the next question, guys. You can see here, which hypoglycemic drug increases the risk of UTI? And here, this is again a repeat, guys, repeated many times. Dapagliflozin, it is an inhibitor of SGLT2, right? It's an inhibitor of SGLT2. And whenever I inhibit SGLT2, what increases in the urine, right? So in the urine, two things are going to increase. There is an increased sodium and an increased glucose. Now, whenever sodium increases, what it does, it pulls water along with it. So because of which there can be a decreased BP, low blood pressure, dehydration can be there, right? Whereas an increased glucose will welcome the bacteria and fungus. It would result in UTI. It would result in vaginal candidiasis. So these are the most common side effects that can be seen with SGLT2 blockers, and it is very relatable, guys. It's very relatable. Dapagliflozin is the answer, and that's it. Patient with pulmonary aspergillosis was treated with voriconazole. Which of the following is false about voriconazole? Now, this is another MCQ where the answers are given wrong by many people. Let us have a look at these drugs one by one. Now, number one, this drug, voriconazole, has a high volume of distribution, so it needs loading dose. That's perfectly fine. Now, this drug, its metabolism of voriconazole, it happens by CYP2C19. And all of you know that, even I've discussed this in the section of clopidogrel, that all of us, we humans, we differ in CYP2C19 gene. So the metabolism of voriconazole will differ from person to person. So for some people, I need lesser dose. Some people, I need more dose. So because of this, I use a loading dose. Then I adjust the dose. After that, I adjust the dose based upon what medium. Second point, guys. See, fat decreases absorption of voriconazole by around 30%. So we don't take a risk, and it should be given on empty stomach. That is also true. So by ruling out, the answer that I get here is it should not be co-administered with pyrazinamide. There is no reason as to why it cannot be co-administered. C is the right answer here. It is a difficult one. So if you have done it wrong, it is okay. Go easy on yourself, right? A patient presents with complaints of cough producing tenacious white sputum. Which of the following statements is true about drug that could be prescribed for this condition? Now, this is an easy one, guys. There is no excuse for doing this question wrong. It is a productive cough. Whenever it is a productive cough, how do I make a cough syrup? Number one, I add a drug called as guaifenesin, which is an expectorant. It oscillates the bronchi and it moves forward the secretions. Then I use a mucolytic. So what are the mucolytic we use? N-acetylcysteine, bromhexine, or bromoxime, which is given in the option, or Ambraxol, right? Three drugs are used. N-acetylcysteine, bromoxime, Ambraxol. Any one of these can be used. Plus, we add salbutamol, right? So what happens in case of productive cough, in this case, salbutamol will dilate the bronchi. Guaifenesin is an expectorant. It oscillates the bronchi. And mucolytic will break down the mucus. So in a dilated bronchi, the broken mucus now can easily move in the forward direction. That is what I need to do in productive cough. I need whatever is being produced to move out. But if it is a case of dry cough, then I have to suppress cough by blocking it in the medulla by using drugs like codeine or dextromethorphan. So there is no way I should be using these drugs for productive cough. So look at option A. Codeine, as it is a potent drug and quickly relieves symptoms. It would not in this case. Bromoxime, dextromethorphan is not a rational combination. As I said, cannot be combined. Dextromethorphan alone, right? Again, it is not a rational one. The reason being, again, it is not dry cough. Bromoxime, as it liquefies sputum. This is the right answer, and you understand why it is the right answer, guys. Again, I've taught you this. How to treat productive cough, how to treat dry cough. Even I've told you, right? In the lectures, I teach in my lectures and I say how the drugs, cough syrup is made for productive cough, but I tell the people in a lighter note, don't make it at home. You get it already ready-made, right? All right, inhaled nitric oxide is used for, yes, it's a frequently asked MCQ, persistent pulmonary hypertension of newborn. And for pulmonary hypertension, there are a lot of drugs we can use. We can use prostaglandin I2 analogs. We can use like epoprostenol. We can use endothelin antagonists like bosentan can be used. We can use phosphodiesterase 5 inhibitors like sildenafil can be used. We can use riociguat can be used. So these are drugs which are primarily used for treatment of pulmonary hypertension. Antihypertensive drug that can be used are CCBs. But remember, these are poor. These are not that good drugs. So an old MCQ they would ask you which is an antihypertensive used in pulmonary hypertension, CCB, right? Out of these, if they ask you which drugs are best, the best drugs are prostaglandin I2 related drugs. So here answer is option A, right guys? Now question number 17, cannabinoids are not approved for treatment of. Now if you remember, I've told you guys a drug called as cannabidiol. Cannabidiol, which was approved a couple of years back, and it was approved for treatment of seizures which are difficult to treat, like Lennox-Gastaut syndrome. Yes, we use it here. Dravet syndrome. Yes, we use it here. Now, we are left with two options, and if you could rule out two options, you should go for one answer. The answer would be Rett syndrome, because if you remember, I have told you this, in Rett syndrome, the only drug, it was approved in 2013, and it is trofinetide. So you could have answered this actually from this MCQ of 2013 AIMS. There is no other drug. There is no other drug in Rett syndrome. This is the only drug, right? Remember, tuberous sclerosis has also seizure. Seizure can be seen in tuberous sclerosis. So it is, if you know that tuberous sclerosis can cause seizure, again, this you could have ruled out. So these are the uses of cannabinoids. So remember, cannabinoids, the uses are S. S for sclerosis, that is tuberous sclerosis, and mostly for S for seizure, like Lennox-Gastaut syndrome and Dravet syndrome. So these are the primary uses of cannabinoids. And cannabidiol side effect, remember, it's since they'll ask you what is its side effect in future. It is hepatotoxic drug. So it is not to be used in children less than 2 years, is what is in the FDA label. So it is an FDA approved drug for only 3 conditions, right? Well, guys, we have reached to the last MCQ. It's a clinical one. A 45-year-old patient presented with enterococcal endocarditis who is allergic to penicillin. Which of the following drugs should be preferred in this patient? Now, I know a lot of you guys looking at this, allergic to penicillin. Oh my God, let us mark AstroNav. You have done that, isn't it? No, that is not the right answer, guys. First of all, try to understand this. Enterococcal endocarditis, it is a gram-positive infection. And AstroNav is effective only against gram-negative. Have I taught you this or not, right? Then, if you remember, the first introduction to antibiotics, there I teach you how to teach infections. And whenever it is endocarditis, I use ampicillin or vancomycin plus gentamicin. So I've taught you this. Now here, if I'm not able to use a penicillin, because of what allergy, let us see, can I use piperacillin? No. If the patient is allergic to penicillin, he is also allergic to piperacillin. It is also penicillin. If a patient is allergic to penicillin, he's also allergic to ceftriaxone. He's also allergic to carbapenems. So even if you don't know all this nonsense, you can still answer from my lecture. The answer is vancomycin. Right, guys. So here we have discussed all the questions which have been asked. It is a mixed bag questions. Some were easy, some were difficult, some were like out of this world, like the one they had asked you about, which is HER1 blocker. But nevertheless, no matter how the MCQs are, all of you know that we always have rank 1, 2, 3, 4, 5, 6, and ranks are there. So do not lose heart over those MCQs which are difficult and you could not solve. It's okay, right? You should be worried about those questions which are easier one and you could not solve them. For those, you need to go back to your notes and see what was the reason you could not solve those MCQs from the topics. Was it a deficiency in your understanding of the topic? Was it a deficiency on some points? Right. So what is the reason? Analyze that. For those guys who could not do well in INI-CET, right? Let me tell you, I've told this time and again on social media as well. When I gave AIMS exam, I even could not qualify for AIMS. I did not even get 50%, right? But because by the time of AIMS exam, I had not revised even once, right? After my second revision in the All India mock, my rank, it came down to 500, less than 500. Just imagine from not being qualified to 500, what revision does to revision. So you have 1 month, whole 1 month, 1 month of revision can make you a different person. Going forward, you have to believe in yourself. Believe that, yes, I can do it, right? Don't lay down your weapons. Don't remember why did you start this. And 1 month, only 1 month, bear with yourself and always keep your parents in mind. while doing all of this, guys. And I have, to the best of my abilities, I've tried to explain whatever I could, guys. And I wish all of you all the best for the next 1 month of revision going forward in NEET PG exam. And may God bless you all and God be with you all, guys. Take care. Lots of love. This was Dr. Ranjan with you.